Hi guys, welcome back to Code Master Coach, your medical coding tutor. Guys, today we're continuing our review of the 2024 official ICD-10-CM coding guidelines. Remember, if you're following along, make notes in your books, write in your books. I encourage my students, write in your books. Make these guidelines make sense. This week, we are at Chapter 10, which is on diseases of the respiratory system. These codes can be found at J00 through J99, and also included are our new code, UO7.0. We're not going to get into UO7.1 just yet today. All right, we're at A, chronic obstructive pulmonary disease, COPD, and asthma. Number 1 is on acute exacerbation of chronic obstructive bronchitis and asthma. And I have on here straight from the guidelines. So let's look at our guidelines when it comes to the acute exacerbation of chronic obstructive bronchitis and asthma. The codes in categories J44 and J45 distinguish between uncomplicated cases and those in acute exacerbation. An acute exacerbation is a worsening or a decompensation of a chronic condition. An acute exacerbation is not equivalent to an infection superimposed on a chronic condition, though an exacerbation may be triggered by an infection. So understand what it's saying here. An acute exacerbation is not equivalent to an infection superimposed on a chronic condition. So I did make a note on my outline that just says, status asthmaticus represents a patient who continues to have extreme wheezing in spite of conventional therapy, or who has suffered from an acute asthmatic attack in which the degree of obstruction is not relieved by the usual therapeutic measures. And this really hits home for me because my 2 sons had asthma. One had it really bad. And so when we would get into status asthmaticus, which meant at home I had a handheld pump and then I had a nebulizer machine. The handheld pump was easy for him to take to school. The nebulizer machine was a little bigger. We kept that at home. But if the asthma ever got ahead of the little hand pump, then I could put them on the machine for a little while, and that tended to work a little deeper than the handheld pump. But when at home and the handheld pump or the nebulizer machine, neither one of them seemed to work, and we actually hit status asthmaticus because we had more wheezing even in spite of my conventional therapies that I normally use to take care of those asthma attacks. Then I knew I needed to get to the emergency room, and what the doctors would do there was give a shot. And the shot worked quicker than the handheld pump or the nebulizer machine. An exacerbation of asthma are acute or subacute episodes of progressively worsening shortness of breath, cough, wheezing, and chest tightness, or some combination of these symptoms. So we can see how that exacerbation starts getting worse. It's progressively worsening. Okay, so I hope that makes sense for the acute exacerbation of chronic obstructive bronchitis and asthma. Now let's go to respiratory failure. We're down to number 1, acute respiratory failure as principal diagnoses. When do we list acute respiratory failure first? Let's look at the guidelines. The guidelines say acute respiratory failure as principal diagnoses. A code from subcategory J96.0, acute respiratory failure, or subcategory J96.2, acute and chronic respiratory failure, may be assigned as a principal or first listed diagnoses when it is the condition established after study to be chiefly responsible for occasioning the admission to the hospital, and the selection is supported by the alphabetic index and the tabular list. Remember, the guidelines always tell you this is the rule, but if your alphabetic index or tabular leads you differently, follow your alphabetic index and tabular list. It says, however, chapter-specific coding guidelines such as obstetrics, which we're going to get to a little later, where you're going to learn that obstetrics takes precedence. Poisonings, we have to identify those first. HIV, you have to identify that first, and newborn. So when there's chapter-specific guidelines, then that provide sequencing direction, you are to take those precedences. So again, we're going to learn with HIV, obstetrics, poisoning, and newborns. Those guidelines take precedence over these others. All right, let's see if my guideline says anything else. There's number 1. I just made a note. Respiratory failure is a life-threatening condition that is always due to an underlying condition. Something provokes respiratory failure. There's some condition that you have that's provoking you to get to the point of respiratory failure. All right, we're down to number 2, acute respiratory failure as a secondary diagnosis. So let's see what our guideline says on number 2. Respiratory failure may be listed as a secondary diagnosis if it occurs after admission or if it is present on admission but does not meet the definition of principal diagnoses. So understand what this is saying here. As the principal diagnosis, it's the reason for the admission. But as a secondary diagnosis, some other reason brought you in. Some other reason caused your admission. But while in, or even on the morning of admission, then you go into respiratory failure, then it becomes a secondary diagnosis. All right, let's look at number 3. Sequencing of acute respiratory failure and another acute condition. It says refer to the guidelines. So let's see what number 3 says. When a patient is admitted with respiratory failure and another acute condition, the principal diagnoses will not be the same in every situation. Again, this is one of those things that my students Coach, just tell me the right way to code it. It will depend on the circumstances. So it says this applies whether the other condition is a respiratory or a non-respiratory condition. Selection of the principal diagnoses will be dependent on the circumstances of the admission. If both the respiratory failure and the other acute condition are equally responsible for occasioning the admission to the hospital, and there are no chapter-specific sequencing rules, then the guideline regarding 2 or more diagnoses that equally meet the definition for principal diagnoses may be applied in these situations. And if the documentation is not clear as to whether acute respiratory failure and another condition are equally responsible for occasioning the admission, query the provider for clarification. You need to know what caused the patient to come in. What is the reason for the admission? Make sure I covered everything. I got a note here. The principal diagnosis is the condition established after study to be chiefly responsible for occasioning the admission to the hospital. Ultimately, it will depend on the individual patient's situation and what caused the admission of the patient to the hospital. Straight from the guidelines. All right, we're down to number C, influenza due to certain identified influenza viruses. So let's see what the guideline says on influenza due to certain identified influenza viruses. Code only confirmed cases. Let me say it again. Code only confirmed cases of influenza due to certain identified influenza viruses and due to other identified influenza viruses. That's that J09 and those J10. This is an exception to the hospital inpatient guideline. In the context, confirmation does not require documentation of a positive laboratory testing specific for avian or other novel influenza A or other identified influenza virus. However, coding should be based on the provider's diagnostic statement that the patient has avian influenza or other novel influenza A for category J09 or has another particular identified strain of influenza such as H1N1 or H3N2 but not identified as novel or variant for category J10. Now, if the provider records suspected, possible, or probable avian influenza or novel influenza or other identified influenza, then the appropriate influenza code from category J11, influenza due to unidentified influenza virus, should be assigned. And a code from category J09, influenza due to certain identified influenza virus, should not be assigned, nor should a code from category J10, influenza due to other identified influenza virus. Again, if it's suspected, possible, or probable, then it's not confirmed. Therefore, you cannot use a code from J09 or J10. You just have to go with J11, influenza due to unidentified influenza virus. Let's go back to the outline. We're down to D, ventilator-associated pneumonia. Number 1 is documentation of ventilator-associated pneumonia. Let's look at the guideline. As with all procedural or post-procedural complications, code assignment is based on the provider's documentation of the relationship between the condition and the procedure. If it's not documented, you cannot code it. Code J95.851, ventilator-associated pneumonia, should be assigned only when the provider has documented ventilator-associated pneumonia. Now, an additional code to identify the organism, Pseudomonas, etc., should also be assigned, but do not assign an additional code from categories J12 through J18 to identify the type of pneumonia, because it's already identified as ventilator-assisted pneumonia. And then code J95.851 should not be assigned for cases where the patient has pneumonia and is on a mechanical ventilator, and the provider has not specifically stated that the pneumonia is ventilator-associated pneumonia. So just because they're on a vent does not mean they've got ventilator-associated pneumonia. It must be documented. And if the documentation is unclear as to whether the patient has a pneumonia that is a complication attributable to the mechanical ventilator, then query your provider, because without that documentation, you cannot code ventilator-assisted pneumonia. All right. And number 2, ventilator-associated pneumonia develops after admission. A patient may be admitted with one type of pneumonia and then subsequently develop ventilator-assisted pneumonia. So in this case, the principal diagnosis would be the appropriate code from categories J12 through J18 for the pneumonia diagnosed at the time of the admission. And then code J95.851, ventilator-associated pneumonia, would be assigned as an additional diagnosis when the provider has also documented the presence of ventilator-associated pneumonia. So you can identify it as an additional code after admission, but whatever pneumonia brought the patient in is going to remain your principal diagnoses. Make sure I don't have any notes under number 2. Nope, just straight from the guidelines. All right, we're down to F, vaping-related disorders. Straight from the guidelines. This is a new, well, it's not new anymore. For patients presenting with conditions related to vaping, then assign code U07.0, vaping-related disorders, as the principal diagnoses. For lung injury due to vaping, assign only code U07.0. Assign additional codes for other manifestations, such as acute respiratory failure or pneumonitis. Associated respiratory signs and symptoms due to vaping, such as cough, shortness of breath, etc., are not coded separately when a definitive diagnosis has been established. You've already captured these signs and symptoms, cough, shortness of breath, etc. However, it would be appropriate to code separately any gastrointestinal symptoms, such as diarrhea and abdominal pain. Because remember, this diarrhea and abdominal pain is not captured in your respiratory symptoms of vaping-related disorders. So again, if it's associated respiratory signs and symptoms due to vaping, then don't code those separately. But if it's something unrelated to vaping, such as diarrhea or abdominal pain, use an additional code for these. See if I got anything else. Nope. Wow, that's it, guys. Chapter 11 would have been our next chapter, disease of the digestive system, but those have been reserved for future guideline expansions. So next week we'll be at chapter 12, disease of the skin and subcutaneous tissues. Okay, guys, thanks for following along with me. I will see you next week. Keep the comments coming in. Keep the questions coming in. I'm enjoying this, and I hope you guys are enjoying this as well. Stay tuned, guys. Thanks. I'll see you in the next one.